So welcome, Zayna.
Yeah, thank you, Allison. You guys can hear me okay? Yeah, good.
Yes.
Sorry I was with you. I was in Vancouver for 4 days last week, but I did have to come home for Thanksgiving. Otherwise, I would have just stayed. But I think we can do a lightning talk in this medium. So I don't know. I think, Marlies, you set a big lightning to strike, right? Whenever I talk. Did we get that planned? So a lightning talk, basically, I'm just going to throw like rapid fire stuff at you, and that's just going to make the molecules in your brain that, Allison, not only a good friend, I would call her my sister from another mister, her group really studies and makes better, but this is just to get you your mind space in a generative frame for the work you're doing ahead. So I've just taken a little collection of stuff. A bit of the context that I'll speak from is a lot of my former lives that Allison just talked about. I'm now Deloitte's first ever health futurist, and aging, all aspects of aging, not just the health aspects, is a major green dot, if that's kind of when it touches everything of the firm focus. So lots of stuff we are, putting out there in Canada to shape and modernize and evolve, but also I co-lead our Future of Health work, which is a global Deloitte point of view on the future of health out to 2040. And of course, everything about seniors and aging will be part of that. And in my work with St. Liz as their chief futurist, we wrote a book called The Future of Aging. So I'm going to pull from that a bit. So I heard you're working on 8 kind of problem spaces. So what I thought I'd do is like a helicopter ride and just give a couple cool things I've seen in my travels in each of these domains. Some I know more than others. And so, I am going to focus mostly on tech-enabled models of care or solutions. But, reminder for everybody, right? This is my mantra. Anything you're developing, any layer, any problem you're solving, there's always 3 years of change that you actually have to go through, in my opinion, a design methodology, like you're going to learn today. And Marlies and team are the best. On the technology side or the solution, on the policy side, because usually the reason we're stuck today is because we've got policies or regulations or rules that were designed for 100 years ago that make no sense in the 21st century. Like, in Toronto, by the way, we still have laws on the books about how to park your horse and buggy. We didn't get rid of them. And then the third is obviously the human layer and all the design around creating an amazing experience for humans, all the humans that touch the thing. But why do we focus on tech? Why is CABI scaling? Is because nothing can be done at a scale that's acceptable from a cost with an amazing experience if you don't have a technology component. It's almost impossible. And so I'm going to focus on things that we wouldn't be able to do if it wasn't for technology. But I will say that doesn't mean the other things go out the door. And I think we need to dispel myths, and I'm sure you're doing. The data is now coming out that, just like I try to get my teenagers off the screen, particularly people in multi-residential settings, they're on screens a lot. And so there's almost like a swing too much the other day. And as you know, with anything with facility, with technology and tools, there's always a segmentation. I have an uncle who's my age who, to this day has never used a bank machine before. He only gets cash at the bank. Great. But that's not the majority. So just keep that in mind. This is always for those who are able, but they're increasingly able. My biggest imploring to you is there is no shortage of emerging tech solutions that are helping solve the same problem set you're solving. CABI sees almost all of them in Canada. The left, this is one of many market maps I collect of Geron Technologies. I forget if this is CB Insights or one of those. And there's all these segments that they start to cluster into. And I put a star next to the ones that map a little bit to what you're doing. On the right, AgeWell, did their map for Canada, and you'll probably recognize a lot of the logos, again, clustered into some segments. So my biggest advice is please don't build anything new. It's been done. Do a little Google search. Find a partner that's figured this out, and you focus on, in my opinion, that policy layer and that people layer, because you are the people who touch patients and clinicians and family members. Technology providers don't. And so I'm going to pull from a few of these that get me excited. Here's what I'm going to ask you to do. And Marlies, I might ask you to help me. If you could just take your little sheet of paper wherever you are and make a line down the middle. I'm going to show you 15 or 16 cool things. 1 or 2 of them is going to make your brain go, huh. So put that on the left. And on the right is like, what's it making you think about for the problem you're working on or the area you're working on? So just so that you don't get excited by my energy and all the slides, and you've got something useful. And I'll check in about halfway and just see if anyone wants to share something they're writing. Otherwise, this will be your work to take into the next lightning round. Okay, are we good to go, Marlies? Anything I need to check in before, or Allison?
Zayna, we're good to go. We're good to go. Thank you.
Okay, so navigation, here's my thing about navigation. There is no shortage of every health org, and buddy's made a blue book or a website or a resource repository. The problem is it's like, giving somebody the phone book. Those of you who were not born in the 80s will know there used to be this thing that you had to open and search to find a phone number. So I think the name of the game here is how do we make it extremely easy to find the resources versus creating, some know-it-all who's going to know a human who's going to navigate all the services. So right away, I started thinking this has not been done, but I don't know if you guys saw this viral tweet that went out last week. This is me all the time. So you go to park and there's like these rules and these hours of the day, and only if you're wearing a red sweater today. And so this guy who's playing with use cases of ChatGPT literally took a picture and said, ChatGPT, can I park here right now? And ChatGPT gave an answer. So I think this is going to be the new thing where there's a myriad information that, either a person themselves or a navigator wants to, and the days are over where one org is going to know it all. And so I would be thinking about that. We met with a private health insurer the other day at Deloitte, and, our staff all have some kind of health benefits program, which is like a PDF document that, like, I have a PhD and I wouldn't know how to find out if X is covered or Y is covered. One of my AI people built a thing in an hour that basically just talks to the PDF document and says, if my doctor prescribes Lipitor, am I covered? And then it'll say, well, how many milligrams, how many days a week, what was, and it goes back and forth and it tells me everything I need to know. So I think this is going to be huge for navigation. A lighter version that I love to talk about, especially during COVID, this was Commerce Bank in Australia, where a lot of older adults, first of all, couldn't access the bank. And secondly, there are a lot of programs, services, rebates, tax incentives to help older adults age in place. As you imagine, if you're on fixed income, which most aging adults in Canada are, which is below the poverty line, you need to access these, but my goodness, you need a tax team to help you navigate them. So this bank created a solution that is a benefits finder, and they can quantify in dollars how easy they help older adults access the benefits they have full access to. And so something like that, I think, could be kind of cool in this context. Okay, you guys have a problem statement around, most of the people who show up at our ED, many are older adults, and we do a one-size-fits-all, as ED model, including our triage. I don't have to, share more that there are many, many really successful designs of geriatric emergency management models. I think what came out of Mount Sinai Hospital under the leadership of Dr. Samir Sinha is probably one of the more advanced ones. When I was at St. Eliz, we designed a model, and what I'd encourage you is, I'm finding across Canada, provinces are creating new pots of money to innovate on ER flow. So you don't have to do it within the operating budget of the hospital. You get this new capital to have the working capital to try some kind of a geriatric model, works, and then that exactly what we did when I was at St. Eliz, where at Sunnybrook Hospital, a lot of people who showed up were older adults who were frail, and really the reason there is they don't have support at home. A St. Elizabeth PSW or nurse literally meets them there, takes them home, and those weeks for them and managed at home. And that's diverted a lot of ER visits. So one idea. Another one is get out of the ER with them in the first place. I am shocked in Canada, we have yet to embrace an ER at home model, particularly for our frail seniors. This model is scaling across all the United States, where the health system partners with, again, the tech company who also has the humans to literally bring the ER into the home. Their data is incredible. They're diverting 40 to 70% of people from coming in the first place to the ER, or they're intercepting them at the ER and bringing them home like we did. And as you know, once you show up at the ER, 40% of the time you're going to get admitted. So it starts to affect the flow. So I just think dispatch should come to Canada. I'm surprised they haven't yet. Okay, I'll do two more, then I'll stop and check in. So I just did a couple. Again, go to your sheet. Is it making you think about anything? Okay, socialization and connection. You know, in our Future of Aging book, you know, we gathered 350 signals around the world of like aging ain't going to be anything like it's been for the past. And Daryl I think set that stage. So just reminder, like our boomers today had an amazing life, and we're kind of the first to do a lot of things that are normal in society. So on the top right, the Silver Snipers, this is the top gaming team, killing the teenagers at all the gaming competitions because they were gamers since the Atari age. They've got time on their hands, they're disciplined in their training, and they're very sharp, and they're winning a lot of money. And so, you know, on the left is the Washington Wizards. So, you know, I've got season tickets for the Raptors, and it's like young women and men with hardly any clothes on dancing to rap music. At Washington games in the NBA, the Wizards come out. This is an elderly dance troupe, and they're killing it. And in the bottom is a pop band in Korea that your intake criteria to be on this pop band is you have to be a centenarian, 100 years old or above in a pop band, okay? So K-pop. So I think just thinking about that, you know, this orientation out of a deficit model, but these are not just cool things in exercise, but it's also kind of a social construct of aging we haven't seen. Of course, other programs, and I know you're looking at these, I think Canada's done a pretty good job, is anything intergenerational, policies, programs, housing. I think Sweden and Denmark and Netherlands were the first. Basically, you know, you get to go to university for free in those countries because you live in a nursing home. That's how you get your board. But so there's this value exchange. We're starting to bring that into across Canada. And I love Papa, although I think they just went under, but they did very well for a long time, which is like an Uber for grandkids. So similar idea of matching services. So I think anything intergenerational is going a long way. The last couple about is, you know, there's a whole literature, and we did a whole chapter in our book on, you know, the word retirement is done. 65 years old is such an arbitrary age from Germany many, many years ago. So it's really about rewirement, multiple encore careers. Most new entrepreneurs are over 50. The gig economy are mostly over 50. Alberta has doesn't do the top 40 under 40. We don't celebrate youth. We celebrate top 70 over 70. So again, any things that create meaningful employment, whether that's paid employment or volunteer-based but skilled employment, creates a sense of, it reinforces a sense of purpose, but also participation in the labor force, which brings in money, which frees up capital to offset the fact that most of our seniors are trying to survive off CPP, which is actually not possible. One of the areas of like people killing it, making a lot of money are grandfluencers. So there's now databases about how much they're raking in. This is a whole industry in the influence economy. Okay, I'll do one more, then I'll check in. So advanced planning, lots going on here. I'll just share a few that I get excited about. Willful is a Canadian company. When I was at St. Eliz, even though we were a nonprofit home care, we invested in Willful. So we put in equity because we see every day, we do 10,000 home care visits a day. 15% of our patients are at end of life. And we see this over and over again, that they did not plan for end of life, not just, advanced orders around medical, but everything. And so we loved Willful because they just make it very easy with a beautiful customer experience. My buddy John Nosta, who just gave the keynote last week in Vancouver at Reboot, he wrote a great piece about what could a digital twin do to rethink end-of-life planning. So how do you have a digital mirror of your whole medical and social context so that it's very easy to kind of plan end of life? So lots of stuff happening there. I think it's emblematic of a broader suite of technology that I call necrotech. Everything about planning for end of life, the stages before end of life, dying, funeral, and how you memorialize after. All of that is up for grabs. Like, you're going to look back and be like, wow, when people died, you went and put them in a box underground and you went to this building and mourned. Like, all that is changing, and it's a huge new area. And this is kind of emblematic of a theme of people dying on their terms, including the location where they want to die. I'm sure you know 70% of Canadians surveyed prefer to die at home. 70% of Canadians die in hospital right now, but also everything about it. Okay, I'm going to stop there and see if the lightning and showers have crowded the room. Marlies,
yeah, our brains are exploding. I do have a grandfluencer in the room. His name is Jim, and he is loving everything about this presentation. Right, Jim? Do you have a question for her, or you're good? He's overwhelmed. Any other questions?
Lightning is overwhelming.
Yeah, but I that composting thing looked very interesting. All right, you're good to go.
Okay, yeah, I mean, imagine if every dead person became a tree. We solve for climate, and we respect people's lives. Okay, so again, if you're on any of the first four, I just went through some stuff. I'll give you these slides right after as well. Let's move to the next one. So falls prevention, look, this is a massive industry in tech. I think I met 5 companies a week when I was at St. Eliz that wanted to pitch all sorts of stuff on falls detection. I'm not particularly excited by that because I think that's just basic technology. I can do it in my Apple Watch. What I want to talk about are other things. So I spent a year on secondment in the Netherlands at a very innovative health system. And, you know, they were working on like, why the hell do we make people sit in a bed and wear these ugly clothes? And you know how much people decompensate when they're inpatient. So they just started asking all these questions that you see here to challenge, you know, what they called bed centricity. And this was driven by the rehab and physiotherapist innovators in my hospital. And at the same time, you might know, and I think Alberta, maybe BC has really embraced, the UK has a whole social movement for change called End PJ Paralysis. And if you don't know about it, please go get it and adopt it. But just getting us out of the mind frame of pajamas and the paralysis associated with it. And that's exactly what our hospital did. We started our movement in the Netherlands called Ban Bed Centricity. And we had multiple things we did, and there's a bunch of PowerPoint on this online. I just wanted to share one just to show you. Look at the clothing we changed for people inpatient. When you show up at our hospital, you pick your clothing if you were doing surgery so that you don't need to wear the nasty blue with your butt hanging out, but you can kind of have some honor, and we can get our ports in and out and check the wound and what have you, as well as in our inpatient beds, the beds are put away. They only come out at night when it's time to sleep. Believe it or not, you are up and vertical and moving during your hospital stay. So I think that's one I thought that is an indirect falls prevention. Of course, lots of technology to extend the labored body. So machines, exoskeletons, clothing that can push your body up. And all of this came from 2 other industries, as you know. Sports, where, you know, track athletes' pants can actually help them move faster or get more lift or more power. And mining, construction, where people's bodies are bearing a lot of physical load. So we're letting their clothing or their exoskeleton. And of course, companies are bringing this into the health space for mobility and of course, falls prevention. I just want to say there's a lot of companies that do monitoring services. TELUS tried to launch one with Apple for seniors. I think this is not about the tech, it's about the design. You know, I contrast what's been attempted in Canada with remote monitoring and falls detection technology with Alexa launching together in the US. You know, go on Amazon, order it, $20 a month, and it works really, really well for kind of a loved one to know if something's going wrong. So again, it's less about the tech and more about what's the experience model and how do you scale it so that it's got a cost that's acceptable to everybody. I also cover a lot on or look at transportation. I think seniors and older adults will reinvent medical transportation. And so, you know, Lyft and Uber and, you know, Ford Motor Company, who can't make money off making cars anymore, you know, has an entire business just for medical transportation. And in the US, where driverless cars are becoming normal, you know, entire companies creating models, you know, where older adults get around using, you know, driverless vehicles, great experience, and they can fit a wheelchair and they can fit whatever is needed. It's not like a Maserati. Last ones, a big thing in mobility, I'd say, is give people tools they already use. If people are already using an iPad every day, and it's a very high uptick technology, or their TV, or in this case, Wii or Xbox or whatever, this is Promenade, where a person can have an experience of walking through a forest and can hit the butterfly or kill the rabbit or whatever, but you're not adding a new thing that they have to learn and charge. It's seamless with what they already use every day in their normal life. Same thing with, the Road World Bike, where it's like the biggest bike race across the world that Moditech from Norway brought to Canada. And I think Cabby worked with them. And I love the bowling league, just with a Wii controller, like a massive bowling league all over the United States. Okay, last couple ones, staff shortages. Look, I can give a 4-hour talk on this. I co-lead Deloitte's Future of the Workforce work. I'll just do I challenge you all to not think of this problem as a supply problem. It's a demand management problem. We actually are supply you have should not have to be the people we know every day. So lots of jurisdiction, postal workers, fire fighters. 70% of the call your firefighters take are for old people with medical issues. So they're there anyway. They can do IVs. They can, in India during COVID, they delivered medications, vaccines, drove people around. As civilians, in Canada, whereas we went to like hospitals to jab people in an arm when we needed to back population, NHS knew there's no way they're going to get the reach using nurses and doctors. They trained civilians, cleared their priority population, which was the elderly, and then they went back to the normal healthcare system. In Sweden, they've been paying a salary to a family caregiver since the 1950s. So think about it. They started doing that 60 years ago. They're innovating on how they pay family caregivers ever since. Whereas here in Canada, it's just being discussed now. Should we pay a wage to people who, do not work because they're taking care of a loved one? And then just other things like this school, if a kid in high school comes and, does the lawn for somebody, they get a physical education credit. So again, thinking creatively about where you get help. And of course, my favorite story that blows up every orthodoxy of the health workforce, particularly for the elderly, particularly in the home setting, is Buurtzorg out of Netherlands. The fact that the founder of this, which was a community nurse, is one of the top 50 thinkers in the world, alongside Malcolm Gladwell and like Roger Martin, and the book Humanocracy, which is the new org model, which is not bureaucracy and hierarchy, but no more managers, no more levels, no more layers. That makes no sense in healthcare. Buurtzorg is one of the 5 organizations in the world that's run as a humanocracy org model instead of a hierarchy org model. So a home care nonprofit from the Netherlands is kind of leading the world's thinking. So many things they challenge. I'll just call out a few. No managers. All the cost of overhead is put into paying 30 to 40% higher salary to their home care workers. They have very low turnover, and nurses and personal support workers, they self-organize and they take care of a community. They're not doing tasks mandated from the center. Okay, on the workforce, whether we want to or not, Pero the SEAL or whoever you have in the room, you will all have digital companions, either for socialization to help us, solve messy things like, should I park here or not? But more importantly, for activities of daily living, for instrumental activities of daily living, and for things like Tai Chi classes, which I've done a Tai Chi class with Pepper the robot in Berlin. So Japan, which, as you know, was one of the first countries in the world to reach the status of the super aged. So when 1 in 5 people over 65, they mandated last year that the government will pay for 4 out of 5 older adults to have to some report as a policy, because there's just no way they're going to keep building nursing homes. And then, we build a lot of these at Deloitte. So we've been working on a pharmacist digital assistant, and we just shared, and you can get the QR code, a demo of one we built for the Ottawa Hospital. So post-discharge from hospital, this is your partner, your care partner. You talk to her and you tell her what's going on, and she checks in if you're taking care of your wound and whatever. But, obviously with an AI engine, but human empathy And it's just like a nice thing to fill the gaps while you're waiting for like a visit in 2 weeks. Last thing I'll just say on workforce, I think all of you who are in the business of recruiting people, you know, that whole process is up for grabs. I think we have not modernized in healthcare how we recruit. So just some examples. I was just talking to Sienna Senior Living. You know, they've unleashed ChatGPT to their HR people to say, like, let it draft the first job spec. Let it screen the first round of resumes, and then you do what you add value to. So lots of ways you can take a ton of time out of recruitment, because if you know you need to keep recruiting and hiring for thousands, this has to be as effective and efficient as possible. Tons of Canadian technology companies with tech that makes it way smarter, faster, cheaper, better for background checks, for credentialing, for helping your own staff promote positions so you can get the word out and they get paid when they do that. That's what Caribou does. And then of course, Staffy, which was a Deloitte kind of top 100 Canadian company last year, just the whole supply chain of finding talent they're innovating on. And then finally, everything about onboarding, training, etc. Using tools like virtual reality and more, you can really, really shorten the time from the old school model, which is sit in a classroom and learn from some educator. That makes no sense in the healthcare world. I just literally said in a webcast today, the future of clinical training is at the bedside. You're going to get what you need when you need it. It's not going to be that you went to school 6 years ago and you're supposed to remember something, including for patients. And then last thing is, Deloitte builds a bunch of tools that we can crawl and scrape like your annual survey of your employees for great places to work and find insights that actually tell you who's at risk of leaving, why they're at risk of leaving, so you can intervene very surgically. Instead of what we do today is we try to do global culture things or try to make it, use wages as a retention lever. So I'll just give you a couple examples. When we did this with a healthcare org in the US, it turned out why people were leaving is they could never get a parking spot when they showed up at work. So it's not worth it. When I was doing this in our work in home care, why people were leaving is they get paid every 2 weeks. Well, they can't float the cash flow every 2 weeks. So we were looking at pay the home care worker the day they work. Paying every 2 weeks is a relic from the industrial era. It makes no sense in the 21st century, as an example. Okay, community, lots going on in community. I'll just do a couple I like. My dream for any regional health authority or community is that any day you can push a button on the electronic life record and get a barometer like this for a population of older adults, get a composite index of their well-being, who's at risk for social connections, for fatigue, for whatever, loneliness. You can get your medical stuff like blood pressure, BMI, no problem, because that's, I've got 10 of those in my watch. And then you can even quantify impact. This is completely possible today. That's what LifeSpark does in older adult communities in the US. And I would think about that is how you blend social complexity with medical complexity to actually know whether or not what you're doing is working. This is probably my most provocative statement. And like Allison, I'm a PhD biochemist. I used to kill mice and try to come up with drugs. Data science will do more for health of humanity than all the life sciences combined. And I completely agree with this statement. We are just scratching the surface compared to all the drugs to extend life and all the dementia treatments and blah, blah, blah. Those will happen. But getting a handle on data smart and fast is going to be a big deal. And then just last thing on community is, getting people to age where they want. And it's definitely for a lot of people not in an institution, nor is it necessary. So again, who are your partners if you're the institution to get people out of your institution? Atrium Health in North Carolina, they wanted to move care into the home and out of hospital and nursing homes, but they couldn't do it themselves. They partnered with Best Buy because Best Buy is trying to bring their platform to help with aging. And in Canada, Best Buy has been doing a lot of this in BC and Alberta. And so they're now doing hospital at home, with a partner that can scale, and Best Buy can take care of everything about the tech experience in the home. Similar to lab testing, diagnostic imaging, we do not need to make people come anymore to these places. There's a risk for falling when they do. It's an access problem. In the Netherlands, on the left, we are now deploying a self-phlebotomy robot, if you will, in retail settings. And Walmart just launched 2 weeks ago in the US, which they will bring to Canada, test and treat. So you go to Walmart, you get your diagnostic test, and then the pharmacist prescribes the treatment. You've just disintermediated most of the healthcare system. Okay, last is dementia. I'm not going to talk about dementia in front of Allison because that's kind of, Baycrest is a champion in the world. I'll just talk about housing though, and dementia memory care and day programs, because I think this is the way forward. I've been collecting examples of traditional government-funded healthcare delivery organizations getting into housing, and obviously Providence has done that with Dementia Village. But the one I get excited about is, you know, there's a big problem right now with commercial real estate, both office buildings, but malls. Nobody goes to malls anymore. And so converting this real estate into memory care sites that are just like the daycare you would put your kid into, which is, you know, it's retailized, it's everywhere in your community. Town Square is my favorite nonprofit in the US. It's a foundation. So their design principle is it has to be affordable. So $95 a day for a day program for memory care. That's less than I pay for my kids to go to daycare. But they work with an academic centers on memory, reminiscence therapy and reminiscence science. So where the environment looks like the time when their participant most formative memories. And so it actually changes their behavior. So it's not just beige and boring, you know, kind of looking like a hospital kind of thing. They really make the design and the experience part of the, if you will, therapy. And they got it as a franchise model. So this thing can scale just like Foot Locker, which, by the way, I think by now we should have a Foot Locker for seniors, but that's a different thing. So, okay, I'm going to stop there. Hopefully you got one or two ideas and reminder, you know, tech lets you do things you couldn't do without it, but you cannot design without policy and the human-centered design you're about to do on all the people impacted by what you're going to see. Thank you.
Amazing. All right, love the green glasses. So you mean that we could actually work without a manager, Zayna? Like how? I couldn't live without my manager. I'm kidding, I don't have one. But I love the idea. Who has a question for Zayna? This is your, oh, popular. Here we go, number one.
Thank you. Excellent presentation. I really was blown over by the presentation. I focused on necrotech. So this is a great idea, but how do we make this acceptable to people since death and dying are taboo subjects for most people? Thank you.
Great point. I mean, I think it's like any of these, to be honest, everything's taboo. We've got our own biases of what we think people will or will not tolerate and can and cannot do. So I'm finding by getting some early adoption, it's normalizing. That's what's happening. And then word spreads and then off it goes. But I agree. I think it's, you know, Canada's very conservative.
Oh, one more over here.
Hi, thank you so much for your presentation. So many great ideas. Through your presentation, I was trying to think from an equity lens, thinking of First Nations,
Yep.
Inuit, Métis peoples, and other folks who live in rural and remote communities. I wondered if you could speak for a moment about examples you may have come up or may have come across for Indigenous communities in this country or anywhere across Turtle Island.
Yeah,
thank you.
We did a lot in our book on this. We actually went to look, okay, who has already, we don't have to rewire the system for aging. You know, we don't have to rewire ageism. Like it's already how they are. It's in their social context, you know, if you will, their social genome. And we absolutely went very deep on Indigenous societies in Canada, in Australia, etc. As you know, the elder is like the most precious person in the community. It's never a deficit model. And so there's a lot of those aspects, I think, that's infused in the design of what these others are doing. If your question is more around the inequities of access, whether that's access to digital, to Wi-Fi, geographic access, language access, all those things are being built, in my opinion, or have to be built in the design of any solution in healthcare. not just for the elderly. We haven't seen some difference of the elderly. I think it's just more the spirit of the elderly, and the model is a big lesson, I think, for all of us in the work we're doing. Just like we're like, let's just go back to how our Indigenous peoples treat the land and use that as our framework to save our planet from being on fire. To me, it's the exact same thing with elderly.
Right. Got another question here. I'll take this one, Josh.
Thanks so much for your presentation. Some great examples. I'm curious, we're seeing in many sectors that, in particularly unionized staff, a lot of pushback against using technology to augment the workforce. What are some of the strategies that you've seen work well to gain acceptance for some of the technologies that you've described to address the workforce shortage?
Look, the best thing, it's a very fair point. We hear this all the time. I mean, I find that's not the biggest reason why a lot of our workforce, kind of refuse to change, if you will, but it's a reason sometimes. One is, if the thing is so obviously easy to use and makes their life better without anyone telling them that it's that's where you have your best chance of success. So I'll just give you an example. The HLTH health meeting just ended in Vegas. It's kind of the big future health meeting. They now have the data, 20% of clinicians are using AI every day in their work, more generative AI, ChatGPT. There was no change management program. Nobody told them to do it. They didn't have to do a big implementation like of an electronic medical record. It just works for them. It works in the tools they use. So just like I talked about, like, tools that you're asking older adults and their families to use that should be ubiquitous already, what they're doing. That's the same, I think, solution for workers. The second, though, is where you're actually going to unbundle their job. And by the way, 70% of what every worker in healthcare does today will be unbundled. Either a machine will do a good portion of it, and then some other type of resource can do most skills. And then there's a little bit left that trained person and their credential and their regulatory college can only do. But most of it will change. So I think starting a vision and a conversation in your org about how are we going to make that transition. So it's not should we, like, you're going to have to, or else you can't do it. So I think it's I hate the word change management, but it's preparing the workforce for a very different way of using their skills and talent, and technology is just one of the drivers.
I have a question, Zayna. We have a group that's looking at the mindset of medical leadership. Okay, we could say a lot about that, but historically we've said don't touch tech because it's impossible to penetrate a provincial health authority or a health authority. The bigger, the harder, potentially. I'm from Alberta, so I know this. So what do we do here? We have all these great ideas.
Oh, yeah, you just hide it. You don't talk about, oh, we're going to get tech and now we need to do this thing called procurement.
Right. Oh, you'll never survive the procurement process.
No. So you don't talk about the tech. So I'll just give you an example, right? So, when, you guys hire Marlies and the pivot group to do whatever they're doing, Marlies and the pivot group use some technology. She probably uses a cell phone and a computer and a couple other things, right? She doesn't say, oh, you have to procure the technology that I'm using separately from my time as a human, right? Like, we just bundle it. So to me, that's the answer. So it's really more of a business model, which is the movement will be, because we'll have the data, you pay a service provider or a constellation of them for the result you want, and then they figure out what combination of humans, tech, drugs, devices they need to bundle to get that thing you need. So you're not procuring tech, it's just a partner with the humans. That's the only way, in my opinion, this is going to work at scale.
Very interesting. That is very stealth. I love that approach, because we are using my computer today and I didn't have to go through any privacy agreements to get it signed off. Okay, questions. This is your chance. Quiet, everyone's stunned, because now we're going to have to focus on policy and people and not create an app today. All right. Well, thank you, Zayna. It was amazing to see you again. Thank you for agreeing and doing this on the fly and incorporating the how might we's. That was incredible.
I love what you're doing. I'm going to brag about you to everybody, and you're in good hands with Marlies.
Thank you so much.
Bye.
It's always really hard to go after Zayna. But I am very pleased to introduce Michael to come up here to introduce our next speaker. Michael, where are you? Awesome. He's from way back there. I'll introduce him. Michael Klephoff is a communication and community manager for Innovate BC, and they are our sponsor for this event. And Allison, I'm sorry I didn't introduce you earlier. I was a little flapped. All right, here you go.
Thank you so much. Thank you. Wonderful to be here. Thank you so much for having us. We are so pleased to be sponsoring the event this year. It's been very exciting. It's been great to talk to the table and the people at the event today. As mentioned, my name is Michael Klephoff. I'm the Communications and Community Manager at Innovate BC, which gives me the wonderful opportunity to attend fantastic events like this one. For those of you who don't know, Innovate BC is a provincial crown agency, and we operate under the direction of the Ministry of Jobs, Economic Development and Innovation, JEDI, and we help foster innovation across the province so that British Columbians can benefit from a thriving, sustainable and inclusive innovation ecosystem. We work to strengthen BC's innovative capacities, forge new connections, harness data to inform forward-looking policies, and celebrate the province's innovation success. Our programs are also helpful in developing talent and just building out capacities in sectors such as healthcare, which we're very privileged to be a part of and support. On that note, we are so pleased to be a part of today, and I am especially excited to introduce our next speaker, Dr. Lillian Hung, who has an incredibly impressive resume. Dr. Hung is an assistant professor at UBC and Canada Research Chair in Senior Care, and is the founder and head of Idea Lab, which brings people together to contribute to innovation in dementia care and aging. Her research examines how technology and environment can impact the care experiences of persons with dementia. And with expertise in patient-oriented research and knowledge translation, she has been committed to facilitating connectivity between academia and practice, and working collaboratively with interprofessional practitioners to find practical solutions to address pressing problems in care settings. So please join me in welcoming Dr. Lillian Hung. Thank you.
Thank you so much. Thank you. I'm so happy to be here. I used to work in Providence in MSJ. Some familiar faces. Nice to see Buffy there, and a lot of friends here. Yeah. So I want to tell you stories about social connection today, and something about design for equity, leaving no one behind. So I'm going to start with telling you a little story, Mary and John. So it's a typical story. Anyone who worked in long-term care would know the stories, yeah. So Mary and John, they've been married for many years. John moved to long-term care. John has dementia. John hits the staff and he refused care. That's difficult, right? We see that a lot of times, yeah. So Mary used a telepresence robot to stay connected with John. So Mary was able to talk to John whenever John needed him. So John got settled, and Mary was able to talk to John on a daily basis, every day, and the staff was able to provide care. So that is a good story. So today I'm going to show you how these robots work. I'm going to show you a few other robots that we work in the lab as well. Yeah. So for that story about Mary and John, I think we've been using those robots for over 2 years now, and Mary and John continue to use those robots every day. And yeah, so it's really interesting that I think that how we can learn from what we hear from the previous speakers about how we can support people with dementia in the care setting to use technology. So I have a lab in UBC. It's called Idea Lab, Innovation in dementia and aging. So we have students that are from all these different disciplines working with older adults together, and a lot of our older adults with lived experience, and they're experts living with dementia as well. So we'll go to the next slide, and we acknowledge the land acknowledgement, of course, yeah. We go to the next one, thanks. So you can see Jim on the telephysicist robot that he's been using the robot to help us to do the research. Jim is our co-lead of the telepresence robot research. This is a picture showing that we were doing a long-term care research in a care facility. Jim was in Surrey and connected with the robot that during the COVID pandemic. Then he was talking to the staff in a focus group, and he was talking to residents and asked them about what was it like for them to be in the care facility. It was a Happy to Eat project and looking at how eating in the dining room was like for them, yeah. So I'm gonna show you this video will show you how the robot works, yeah. You can see the robot went into the care home. So these robots are controlled by the family. So the family could log in and connect. This is a pet visit.